Thank you for joining us for today's workshop, Foundations of Syphilis. For your information, this workshop will be interactive, but I ask that you please keep yourselves muted for now. The chat box is available if you have any comments or technical support questions during the presentation. As a reminder, this workshop is being recorded, and the recording will be available on the Saskatchewan Prevention Institute website in the coming days. Before we get started, I want to acknowledge that I'm in Saskatchewan, which is located on treaty lands 2, 4, 6, 8, and 10, the ancestral territories of the Nahinawak, Nahitawak, Nahayawak, Anishinaabeg, Nakaway, Dakota, Lakota, Nakota, Dene, and the homeland of the Métis. We recognize that these lands are currently inhabited by Indigenous people from across Turtle Island, including many other First Nations and Inuit people, and acknowledge the importance of the treaties, the lasting impacts of colonization, and continued inequities. We are dedicated to moving forward on a shared path of reconciliation and partnership. We are all treaty people, and we're grateful to live, work, and play on this land. So my name is Abby Gertzen. I'm the Sexual and Reproductive Health Program Coordinator at the Saskatchewan Prevention Institute. Our mandate at the Institute is to help all children thrive through primary prevention and the promotion of well-being. We believe that all children of all abilities have the right to the best physical, social, and emotional health possible. Our goal is healthy children. We provide education, training, and capacity building across 6 main program pillars: early childhood mental health, prevention of child abuse and neglect, prevention of child injury, prevention of fetal alcohol spectrum disorder, perinatal and infant health, and sexual and reproductive health. One goal of the Sexual and Reproductive Health Program is to provide educational sessions for health and allied health professionals and the public about STBBI and reproductive health. So this workshop today is designed as a foundational overview of syphilis for frontline service providers working in community-based organizations serving priority populations. Participants will learn the basics of what syphilis is, how it is passed and prevented, signs and symptoms, and the importance of testing and treatment. By remaining up to date with emerging trends and evidence, we help to ensure that the care we provide is rooted in best practices that are safe, equitable, and responsive. So here to present to us today is Shreya Hari. Shreya Hari is currently based in Toronto, where she works at CATIE, Canada's official knowledge broker for HIV, hepatitis C, and STBBIs. At CATIE, she is a health educator. Her work includes a wide range of educational delivery, including workshops, courses, and webinars. Shreya's primary areas of interest include sexual health, HIV/AIDS, hepatitis C, communicable diseases, and chronic illnesses. While she technically holds 2 degrees from McGill University and the University of Toronto, in her worldview, the entire universe is her university and therefore her place of learning. So without any further ado, I'm so happy to welcome Shreya. Thank you for being here, and I'll pass it over to you.
Thank you so much for that wonderful, warm welcome, and also for sharing a little bit about what you are engaged in at the Saskatchewan Prevention Institute, Abby. I think it's really wonderful for people to become more aware of that as well. I'm just going to start my screen share here. And so, as Abby mentioned, my name is Shreya. I'm a health educator at CATIE. And I'm so glad that there are so many people joining us today. And as Abby mentioned, today's workshop will focus on this foundational overview of syphilis for frontline service providers working in community-based organizations who are serving priority populations. And so today, the goal is really to provide some fundamental knowledge about syphilis so that frontline providers, such as yourselves, are better equipped to speak to clients about syphilis and support those clients in engaging with prevention, testing, and treatment services. Just a very brief territory acknowledgement from my vantage point here. because I'm not in Saskatchewan. So, I just wanted to share briefly that it's with deep gratitude and respect that we acknowledge that our work at Katie takes place on Indigenous land. And so our office is situated on the traditional territories of the Mississaugas of the Credit First Nation, the Haudenosaunee, Six Nations, and the Huron-Wendat. And this is now home to many diverse First Nations, Inuit, and Métis people today. And it's also where I'm located, so in Treaty 13 territory. And so we acknowledge also that our outreach and education work is carried out on Indigenous territories across the country. Okay, just give me one moment here. And yeah, so just a note also that for folks who are not as familiar with Katie and the work that we are engaged in, I just wanted to briefly share that we are Canada's national knowledge broker, as Abby mentioned. We work in HIV, Hep C, sexual health, STBBIs, and harm reduction. And so if folks are interested also in connecting with me further about our work, that's completely fine, and I would more than welcome your engagement. All right, let's get these slides back up. And so let's just take a moment to sort of go through the agenda for today. So we'll begin with sort of just the briefest of introductions, which we've kind of gone through. We'll move on to syphilis symptoms and progression. We'll chat a little bit about syphilis transmission, prevention, testing, and treatment, and addressing syphilis-related health inequities. And then we'll finish up with sort of practical strategies to look at how all of this can come together in our day-to-day practice, especially with a view to look at syphilis-related health inequities and what does this work really mean? What does it look like to engage in this? And I'm just curious if I can get sort of a show of hands using the hand raise function maybe, or perhaps one of your reaction icons on the Zoom toolbar for folks that are already engaged in syphilis-related work. Just trying to get a sense of the room. Okay, so I'm seeing some thumbs up, some hand raises, or okay, yeah. Yeah, some applauses as well. Okay, awesome. Thank you for sharing that. And if potentially some folks are also just shy about it, so that's totally fine as well. Um, And so, yeah, so we'll dive into our sort of syphilis overview at this point. And just before we get started again, like, thank you so much for the Saskatchewan Prevention Institute for inviting us. And we'll dive right in. So what is syphilis? It's a sexually transmitted infection that's caused by a type of bacteria called Treponema pallidum, or T. pallidum. And so many people with syphilis experience actually no symptoms or don't notice the symptoms. Back in the day, so not in our current iteration of this particular syphilis epidemic, back in the day, decades ago, before we had sort of addressed syphilis in that era, it used to kind of be known as the master of disguises when it came to illnesses. And it's because the symptoms that people do notice can be mistaken for other conditions. And so untreated syphilis also can progress and lead to worsening symptoms. So here are here are the typical stages of untreated syphilis in adults. So there is the stage of primary syphilis. This usually happens within 3 weeks after initial infection. And then there is secondary syphilis, and that usually develops between 4 and 12 weeks after initial infection. You might notice slightly different numbers of, when secondary syphilis shows up, and that's because in some documents they're actually indicating when the stage develops after symptoms show up. So it sort of depends on the document you're looking at, but this is accurate. That secondary syphilis usually develops between 4 and 12 weeks after initial infection. And then there's latent syphilis, where it's kind of like after the primary and secondary stages subside, untreated syphilis stays in the body without symptoms. And then there's also tertiary syphilis, which can begin years or decades after initial infection. It's important to note that most people do not progress to this stage. Um, and so, but it's still something to keep in mind. Then just at the start of these pieces, there is, of course, that initial infection that occurs, right? So just give me one moment here. Yeah, perfect. And so why are we talking about these stages at all? Well, there are certain stages where a person with syphilis is most likely to pass it to others. And so the syphilis stages are also relevant to testing and treatment for a person's own health, right? So we'll learn more about all of that today. So we have a poll question just to get a sense of knowledge in the room. There's about 51 people here. And I'll just go ahead and launch first that first poll. Or actually, my apologies, Abby. There's quite a few polls, and so I'm not entirely. Maybe I can get your assistance here. So for this poll question, would you be able to launch it, please? Thank you so much. So which symptom is often a part of primary syphilis? And you can select all that apply, but it might be a trick question. It's anonymous. We won't know how you're answering. Nobody knows how you're answering except you. You might see your name under your own answer, but that's just for you to know which way you answered. Nobody else can see that, in case people are feeling a little shy. Can happen. So answers are still coming in. About 84% of people have participated. Encourage people to take a guess. If they're not sure, that's okay. We can try guessing. I think that encouraged like maybe 2 people to be like, okay, fine, I'll guess, which is fine. So I'm seeing some comments in the chat as well. You can answer through the poll if you are able to, but if you're not able to, you're certainly welcome to share your thoughts in the chat, either privately to me or to everybody. Okay, I think we're kind of reaching maybe saturation of people's interest in answering the poll question. So I'm going to just end the poll there. I'll share the results. About 90 people participated, 89% participated. So you can kind of see that. So most people answered correctly, but there is some range here in terms of options that were selected, right? So the answer is actually B and only B. So primary syphilis is really characterized by this chancre on, in, or around genitals, rectum, or mouth. And these chancres can develop within 3 weeks after initial infection. And so it is a word that we borrowed from the French, chancre, right? So stop sharing there. And so we'll talk a little bit more about primary syphilis. So this usually develops, as we said, within 3 weeks after initial infection. So some people notice this sore that's called a chancre, right? On, in, or around their genitals, rectum, or mouth. They're usually small and painless and can develop in out of sight places. So a person may not know they have one, right? It can happen sort of like, internally and so people are not fully aware, or just in a not so visible spot. The other piece is that chancres can heal on their own without treatment, meaning that the visible sore, or I should say chancre, can disappear. but the person still has syphilis and can still pass it on to others. And this is something important to keep in mind because clients may, they may think, was that even something? Well, it's gone now. Maybe it was nothing, right? People might not fully know how to how to contend with symptoms that might show up and then disappear. So that's something important to think about. The secondary stage of syphilis usually develops between 4 and 12 weeks after initial infection. So, signs that syphilis has spread throughout the body may appear. This could be a rash on the torso, palms, or soles of the feet, or painless lesions called, and so these are called mucus patches, really. So, when they occur on the wet tissues of the genitals, mouth, throat, or tonsils, right? And so a person may experience fever, sore throat, headaches. This is where you might see patchy hair loss or swollen lymph nodes. So this might actually, I know there were a few people that answered this way on the previous question. This is actually a sign of secondary syphilis. So we have our next poll question. This one, Abby, I think I can do, but hopefully I don't get it wrong. So this is asking, symptoms of secondary syphilis can go away without treatment. Is that true or false? It's kind of fascinating because as I'm seeing the answers come in, there is a piece here where, service providers, even clinicians are adjusting over the past little while to contend with syphilis. This was an illness that uh, we managed to really address with good antibiotics back in the day. Now we're seeing a resurgence, and those antibiotics are still like available, but accessibility. There's a lot of pieces that go into this, but it's kind of fascinating to see, like, is it top of mind for people? Is this something people are seeing? It's certainly something that we're having to take more note of, right? So about 93% of people participate, and this is really fascinating. So we're seeing that like 70% of folks in the room have answered true, 30% have answered false. The answer is actually true. So, the symptoms can go away without treatment, but if syphilis isn't treated, it can still be passed on to others, even if symptoms disappear during the secondary stage. And this might, give some folks some insight into like, well, of course we're going to treat in secondary stage if we come across someone, or of course we're going to link them to care. Yes, absolutely. But I think it shows this important piece around, you know, when are people engaging in care? Uh, are there open conversations? Is there room for open conversations where people can actually share that, there was something, but it went away, right? That's it's a bit of an abstraction. So clients may not be fully aware of even bringing up something that they kind of had that kind of went away, if you know what I mean. So that's something to keep in mind in terms of just practicality. So we'll keep going here. So after the primary and secondary stages subside, untreated syphilis stays in the body without symptoms. And this is called latent syphilis. So at this stage, there are no symptoms, and the infection can only be detected with blood tests. But the disease continues to cause damage. So here's a question. And you can share out loud, but since there's a lot of people in the room, maybe just putting your answer in the chat is probably a better idea. But how long can a person have latent syphilis for? What do you think? Just give folks a minute to think about it. Yeah, so I'm seeing a comment in the chat. Years until they're treated. Any other contributions? I'm seeing 5 years. Yeah, so these are all like pretty much in the ballpark, right? So, and I really actually like that first answer because it is kind of all encompassing. It's just years. And also until they're treated. So the piece here is that like latent syphilis can sometimes last for years, even decades. And latent syphilis within 1 year, we call that early latent syphilis. And syphilis can still be passed during this period of time. Latent syphilis that is present for more than a year after infection is called late latent syphilis. And it's rare for syphilis to be passed to others during this period. Okay, so we'll keep going. And then tertiary syphilis is the most serious stage, usually occurring years or decades after the initial infection. However, not everyone progresses to this stage, right? And for those who do, though, something really important to keep in mind is that any organ in the body can become inflamed and damaged. That includes the brain, nervous system, eyes, ears, skin, liver, kidney, heart, or bones. So at this stage, we can see how this inflammation and damage to organs can result in serious health problems, including hearing or vision loss, nerve damage, erectile dysfunction, personality changes, memory problems, decreased judgment and insight, meningitis, loss of muscle control, damage to joints, seizures, or stroke. So there's really some relevance here in terms of like making sure that we can do our best in getting people access to treatment, getting treated, and then looking into prevention options as well. The other piece is that damage at this stage can be permanent even after the underlying syphilis infection has been cured, because at this stage we're really looking at sort of prolonged damage to organs, right? What do we think? Syphilis is commonly passed to others during the tertiary stage. Is this true or is this false? And as you're answering this question, sometimes people ask about like neurosyphilis. Um, the damage to nerves and so on typically occurs later. However, like the technical piece there is that neurosyphilis can actually show up at any stage during like the course of syphilis, but it's just that like when we start to see permanent damage to organs and so on, then we have like that is characterized by the third stage, tertiary stage, I should say. So about 79% of people have participated. Again, the polls are anonymous. You don't know which way you're answering. Maybe a few more people. There's about 8, 9 people. Just take a guess. It's okay. All right, I will end the poll there, share the results. And yeah, so most people have answered correctly here. So the correct answer is false. Um, so syphilis is rarely transmitted during the tertiary stage. So if a person has a confirmed diagnosis that is suspected to be tertiary syphilis, then the person should be asked to contact or to provide contact information for all sexual partners within like a trace back period of 1 year, according to national guidelines or provincial guidelines where available. So I think like in Saskatchewan, if you do have provincial guidelines around this, I think that would be the one to follow. And so we'll also be discussing actually contact tracing and its importance in reducing the spread of syphilis in more detail later now. Yeah, there's a great question. Did you see these slides in advance? Because that is exactly what the next slide discusses. So thanks, Hillary, for bringing that up. And just a note here as we're moving into the next slide, which discusses congenital syphilis, can be a hard topic for some in the room. So just a content note there that we are seeing cases, as you know, of congenital syphilis. And so, realizing that it might be a sensitive issue. Um, and a new one too, or newish for clients to contend with. So syphilis passed from a pregnant person to a fetus or infant during pregnancy or childbirth is called congenital syphilis. This can result in miscarriage, stillbirth, or death of a newborn. It can also result in an infant being born with syphilis. And syphilis in infants and children can cause very serious health conditions and developmental disorders. So later on in this workshop, we'll talk about, social and structural factors that create barriers to prenatal care access, feeling comfortable in a prenatal care setting. There can be fears for, people that are pregnant, particularly women who are marginalized and they might fear that their child will be taken away. So there's a lot of barriers that are there that we need to address. But there are also supports, right, that can be provided to pregnant people to prevent congenital syphilis. So I think there's just a question. Sorry, just give me one moment while I pull up the chat. Thank you, Janice. Yes, I think that's wonderful. So Janice has posted a clinical resource. And so if that's useful for folks, please go ahead and check that out. And the next piece we have here is just a question. You can answer in the chat. What are the ways you've heard of syphilis being transmitted? What are some ways? Just take a quick look. Yeah, so seeing sex, so vaginal, oral, and anal sex. I'm seeing, I'm seeing oral sex, I'm seeing inoculation. Do you want to share a little bit more about what you mean? I'm seeing sharing used injections, any contact with a chancre. Yeah, so there's a lot of ways in which we can talk about what's happening, right? So basically, oh, and then I think there's one, maybe a final comment. Yeah, sexually transmitted and transplacental. Yeah, I think that really gets at the heart of this. So syphilis is passed most often through genital, anal, or oral sexual contact. Okay, so that is really the main way. So it is an STI, right? Perinatal transmission can also occur, right? So when we have this untreated syphilis infection in a pregnant person, that can easily be passed to a fetus during pregnancy or to an infant during childbirth. What do you think? How can syphilis be passed to a fetus? What is happening? I think there's an answer in the chat that maybe answers that. But what do you think is happening biologically? Like how is syphilis being passed to the fetus? There's that piece around transplacental. Yeah, exactly. So syphilis can be passed to a fetus through the placental wall, through blood, as early as 9 weeks into pregnancy, right? And it can also be passed to an infant during childbirth through contact with a syphilis sore. So this is important. Now, and then the other piece too is that someone also raised injection drug equipment. It's while it's not a main way, it can be. So syphilis may also be passed through shared drug injection equipment. It's not like a, how do I put it? Typically you need larger quantities of blood for transmission to occur, but it may be. So we've included it here. The other piece too is that, like at Katie, we really take an integrated approach to addressing STBBIs. And so using new equipment every time a person uses drugs is a strategy to prevent the transmission of syphilis as well as other STBBIs, including, of course, HIV and hepatitis C, which are really, known to be like quite bloodborne. Um, People who use drugs also remain disproportionately impacted by syphilis due to a range of social and structural factors which create barriers to managing and maintaining sexual health. So we'll be talking more about these factors and the ways that they can create health differences in more detail later in today's session. Okay, so what are strategies that can prevent the transmission of syphilis? So what strategies can we use? Yeah, so I'm seeing condoms and dental dams, sex education. Yeah, education, condoms, dental dams. Great. Thinking about so education, treatment, testing and treatment, screening of pregnant mothers. Yeah, like, prenatal screening and treatment for pregnant people for sure. Yeah. Um, yeah, abstinence when active sores are present. It's interesting, right? Because I think like there's this piece around here around just like education of what that sore could be, and then also just recognizing that people may not know when they have sores. Someone's mentioning port support, which I didn't think would it kind of rhymes. Port support. Denise, do you want to share a little bit about what that is? Prenatal outreach. Yeah, for sure. With Sanctum Care Group. That's incredible. That's awesome. Yeah, and so, really making prenatal care like useful and relevant and a space that feels safe, right? Otherwise, people aren't going to access that care. Yeah, absolutely. Thank you for sharing that, Denise. Port support. It's wonderful. Okay, so, those pieces are kind of reflected here. So condom use for sure, the consistent and correct use of condoms during sex reduces the chance of passing or getting syphilis through sex, but does not eliminate it. And this is because condoms may not entirely cover syphilis sores, right? Which are highly contagious. And that's part of the piece here is that, like no condom provides full coverage of the entire region. Condoms are great when used exactly as as told or when it comes to HIV. But when it comes to syphilis, like syphilis isn't necessarily about the fluid itself. Although of course that's, but it's the chancre, it's sexual contact, right? And those chancres can show up in the region. With HIV, it's different because it is the fluid that is transmitting, right? So yeah, so there's some pieces here to consider. And those syphilis sores are highly contagious. The other piece is prenatal screening and treatment for pregnant people. And these are really the most important tools to prevent syphilis being passed to a fetus or infant. So, national guidelines recommend that all pregnant people be screened for syphilis within the first trimester or at the first prenatal visit as part of prenatal care. Repeat screening in the third trimester and again at delivery is recommended for pregnant people who are at risk for infection or who live in areas with syphilis outbreaks. I'm curious here, has anyone supported clients with prenatal screening or screening in the first trimester or also like repeat screening? Is that something that's come up in the course of your work? That's awesome. I'm seeing a response saying that's what we do in port all the time. Yes. Great. Yeah, I think this is excellent. And so it's also great to see expertise in the room for folks who aren't engaged in this work directly, but you want to get more involved or you want more supports and you're kind of thinking, okay, how do I go about this in my region? I would encourage also for you to get in contact with one another. So we're seeing in the chat, Denise, Tiana, and Janice are saying, yeah, we're engaged in this. I'm seeing Leanne too, she's saying we screen all clients that have blood work. Yeah, so this is, there's some excellent knowledge in the group that is relevant and specific for the context that you're in. So absolutely engage one another in creating networks of support and care. Um, and finally, going back to the slides, there is also this piece around using new injection equipment every time someone injects drugs. And again, this prevents getting syphilis that, when we said it may pass through injecting drugs, so this will prevent, using new injection equipment every time prevents getting not only syphilis, but definitely, other STBBI transmission like Hep C and HIV. So we want to start thinking like holistically, right? There's a new approach to preventing syphilis during sex using the antibiotic doxycycline as prophylaxis. So there's evidence to support its use by gay, bisexual, and other men who have sex with men, as well as among transgender women, but more research is needed to see if it's effective among other populations like cisgender women and transgender men. So when used only after a condomless sexual encounter, this is called doxycycline post-exposure prophylaxis, or doxy-PEP. And doxy-PEP should be taken as soon as possible after sex, but can be taken up to 72 hours after. Doxycycline pre-exposure prophylaxis, or doxy-PrEP, is another approach to taking doxycycline to prevent syphilis. And with doxy-PrEP, a person takes it both before and after a condomless sexual encounter, usually every day. And the evidence on the effectiveness of doxy-PrEP is limited, but studies are ongoing. And I'm just curious, has anyone heard of doxy-PEP and doxy-PrEP as approaches? Curious about that. Seeing, yes, I attended your workshop. Yeah, fair enough. Um, I also thought I would share. So this is a Katie, it's a self-directed course called Syphilis Fundamentals as well. I just thought now would be a good time to share this. Yeah, I've heard of it before from Freddie. Yeah. Um, and so this course, in case any of this is going too fast or you're like, wait, I want to know more about this. Um, there's more information here. Yeah, Gladys, let me find actually a fact sheet that covers a lot of the nitty-gritty of the treatment duration and so on, right? So it depends also on like, is it PEP or is it PrEP? So we'll talk more about it. And we also differentiate. So just so when you're speaking with clients, we really want to say doxy PEP, because otherwise people might find it confusing with HIV PEP. So there's that piece as well. And actually, let me pull up our facts sheet. Yeah, here we go. So Gladys, I think this is a good starting point for that question. And I think it goes into a fair amount of detail as well. So I think this is helpful. Okay, so going right back into the slides here, I have a discussion question regarding considerations when it comes to supporting people in accessing prenatal care. Look, what are some considerations that you've thought about, particularly if you have experience in this, of course? And then what are some examples of services? So we've heard a little bit about PORT, and what services might you offer to support the prevention of syphilis transmission from a pregnant person to a fetus? Stop my screen share there so that it's a bit more lively in discussion. But I can pop the questions into the chat. So again, the two questions under consideration are these two. So I'm seeing from Stephanie, one of our biggest challenges occurs when prenatal clients aren't accessing care in the prenatal period. Yeah, that's definitely a consideration. So Tori, that's a great question. And actually the evidence seems to be for doxy-PEP that this is a useful approach. Also, doxy is used in like a variety of areas, right? Like it's also had relevance and application in like acne and like all kinds of other uses. And so they aren't like I see what you're asking around antimicrobial resistance. They aren't seeing too much of that. We should have more data in terms of what that means for long-term usage in the context of doxy prep. So hope that answers a bit of your question, or maybe it didn't answer it, unfortunately. Um, I'm seeing low barrier care, like walk-ins, flexible schedules, outreach, and transportation are really important considerations to support people in accessing prenatal care. Stephanie, if you want to share more, why is it? Like, what are clients saying about why they aren't accessing care in the prenatal period? What is getting in the way? And if anybody else wants to contribute, please share. So I'm seeing, yeah, living with addictions. Yeah, which is usually also downstream of, a lot of things like homelessness, systemic inequities, competing priorities. Yeah, absolutely. Clients sometimes don't understand the need for prenatal care, right? Or there's like a lack of trust that's built, fear. Yeah. People might not fully trust systems. And, there's a history there to contend with as well, right? Um, yeah. What are some ways that you have promoted prenatal care, particularly for marginalized clients, like if they're homeless, if they've had historical or ongoing and current present day experiences of discrimination and so on? What are some ways in which you can reduce those barriers? Education is important. Yeah, making that education relevant, right? Yeah. I'm seeing at our HMHB program, we have attended visits with clients. Charmaine, do you want to share a little bit more about that just so that people understand the context? I'm seeing meet them where they're at from Andy, building relationships. Yeah, and all that takes time, right? It takes time. Um, Healthy mother, healthy baby. We're prenatal program similar to Port. Awesome. We offer some prenatal classes, which include physician prenatal appointments and serology one-stop shop. Yeah, that can be a huge piece too, right? People don't necessarily have the time or the energy to go from one place to the next, and having like a one-stop shop can be really, really beneficial. Having peer support to connect them, yeah, people within their own community or context who are engaging in this work, building that trust, recognizing that it doesn't always have to be like you as the service provider, right? That it can be peer relationships. Oh, I also noticed that was Danita. We've met before, Danita, so nice to see you here as well. Yeah, awesome. Um, Excellent. Yeah, meeting people where they're at. Great. Yeah, so all of these things are really relevant. And I think we're hearing too that like part of this is of course ensuring that that trust is there so that you can even do something like syphilis testing, right? Um, so what do you think? Who should be tested for syphilis, do you think? Everyone. I'm seeing an answer in the chat. I'm seeing many people writing everyone. Yeah, I think like particularly in the context of an outbreak and so on, and so there's definitely a case to be made there. I'm just going to share my screen once more. Just give me one moment while I bring that up. We'll chat a little bit about that. So anyone who's had a potential exposure to syphilis or who has symptoms of syphilis should be offered a syphilis test or be referred to testing, right? If someone regularly participates in activities that can transmit syphilis, regular testing is recommended and is an important step in preventing the transmission of syphilis. National guidelines recommend that individuals with new or multiple partners should be screened every 3 to 6 months. And syphilis tests should be done alongside tests for other sexually transmitted and bloodborne infections or STBBIs like HIV, chlamydia, gonorrhea, and hepatitis C, because these can be transmitted in the same ways as syphilis. And so frequent testing allows people to be diagnosed and treated as soon as possible. So I hope that gives some additional context. I just wanted to take a brief moment. Yeah, actually, no, that's fine. So we'll keep going with this. My apologies. I thought there was a video coming up. I was like, did I miss it? But no, it's coming up. Great. So let's talk a little bit about the testing process next. Does anyone know anything about the testing process that they'd like to share in the chat? And part of this is also an opportunity to showcase your knowledge, because there are people in the room that could benefit from that, especially if they're in your community or in a nearby region. That can be really effective as well. Like, I encourage people to message one another, or if you see an interesting comment and you want to learn more about the work that somebody's doing, please feel free to do that. So the testing process, any idea? Okay, we'll keep going here. So syphilis testing usually involves providing a blood sample, which is then processed in a lab, and that really happens through these two tests, right? So there's the treponemal test, and there is the non-treponemal test. In Canadian labs, the blood is usually first tested using a treponemal test, which is very sensitive and can detect exposure to syphilis bacteria. But a treponemal test cannot actually tell us whether the syphilis infection is current or whether it occurred in the past, right? It can only tell you that a person either has syphilis or has had it in the past. If this test is positive, then they also conduct a non-treponemal test. And this is looking for, basically, you can think of it like cellular damage. Okay, so if the first test is positive, the second test, called a non-treponemal test, is then done using the same blood sample. And we would use this as well as other confirmatory tests that can help to confirm that a person has a current syphilis infection. So the idea is we're looking for something that is specific to syphilis, but it could be past or right now, right? That's the treponemal test. And then if that is positive, then there is this non-treponemal test, right? So you could ask the question, well, then if somebody's ever had syphilis, is the treponemal test, like, does it provide information, right? And the answer is like, well, no, you would also need the non-treponemal test, okay? Sometimes a swab is taken of the syphilis chancre itself. Now, this has limited use, right? Swabbing, because they can only be done if a person has a syphilis sore or this chancre when they're coming into the clinic. And if that, if they're just sort of like, okay, there's a sore, to even like collect a sample of it. And then the other piece is that certain tests using swabs are not widely available. Okay. Um, I'll mention this as well. So Health Canada has authorized Biolytical's INSTI multiplex HIV-1, HIV-2 syphilis antibody test. So this is a multiplex test for clinical use. And in Canada, this is the first approved rapid point of care test for both HIV and syphilis. And it's the first approved point of care syphilis test of any kind. And so the INSTI multiplex test is a single screening test that detects both HIV and syphilis antibodies using a single blood sample. And the test requires a few drops of blood from a finger prick and produces accurate results within minutes. Results show as either reactive or non-reactive for HIV and or syphilis. And in the case of a reactive result, a vial of blood then needs to be drawn and then sent to a lab for confirmatory testing. And so I can actually share a bit more information on that. I'm seeing a message in the chat. Yes, we will be sending out the recording. So do not worry about that. Or you'll see that recording from actually the Saskatchewan Prevention Institute. Thank you so much, Janice, for also sharing this new clinical procedure for healthcare providers to collect a dried blood spot, so DBS testing as well for syphilis screening. So thank you so much, Janice. There's an excellent link in the chat that is informative. And then she's also shared some information about multiplex testing in the multiplex HIV syphilis point of care testing within the next year. And I'll also share a bit in terms of the national context here. So just give me one moment while I bring that up. Um, so yeah, this is a bit more information about the clinical use of that point of care testing. And given that like this is something to look forward to for the next year as another tool. So there we go. Great. All right, so let's talk about treatment. Um, so we've had syphilis treatment for a long time. And then, oh, my apologies. Actually, I missed a piece. My apologies. We'll talk about contact tracing first, and then we'll come back to treatment. So, yeah, there we go. Yeah. So, according to national guidelines, when someone has a confirmed syphilis diagnosis, the person should be asked to contact or provide contact information for all sexual partners within like this traceback period. Now, the traceback period is the period between when a person gets a syphilis infection, when their first symptoms appear, if they have no, or if they have no symptoms, it's from when their test sample is taken, right? And like this kind of makes sense because from a practical standpoint, that exact date of initial infection is hard to determine, right? It's like when people will show up in a clinic, you kind of have to like sort of back calculate or estimate really based on the suspected stage of infection that you're seeing, right? So the way this is working is that so if somebody has sort of primary infection, right, primary syphilis, then the traceback period is actually 3 months to try and account for, okay, like, because we don't know how long that primary stage is now lasting for, right? Like, as in, so we're accounting for like a full range there, if that makes sense. So it's 3 months of a traceback period if somebody presents with like primary syphilis, 6 months for secondary syphilis, and 1 year for early latent syphilis. So these are by national guidelines. If the client chooses not to contact their sexual partners, the healthcare provider or public health nurse will attempt to contact them and encourage testing and treatment. The name of the client is not given to the sexual partners, right? So there is like, I mean, yeah. So there's a degree of like confidentiality like built in, but of course you can imagine like there are things to navigate in terms of if somebody believes they're in a monogamous relationship and so on. So there are things to navigate there, right? Just from a practical support standpoint. National guidelines recommend that all notified partners be treated without waiting for test results, right? So we're kind of, so you're treating presumptive cases, basically. Okay. And then the other piece is you might ask, like, what about late latent or tertiary syphilis? Basically, there's sort of an assessment around like other long-term partners and potentially children, right? Like in the case of like if there's been a pregnancy and so long. And so the decision to test these contacts really depends on estimated duration of infection. So there would sort of have to be an extension of the length of time for partner notification to include additional time up to the date of treatment. And so there's things to consider. Like if the person sort of states there were no partners during the recommended traceback period, then you notify the last partner. If all partners traced according to that recommended traceback period taste negative, you notify all partners prior to that traceback period. But that's by national guidelines, and there might be some additional information in the context of Saskatchewan. And Jan is so useful. Thank you for sharing that piece there. Amazing. So I won't pop in the national guidelines since there is this Saskatchewan specific note in the chat. What would we do without you, Janice? This is incredibly helpful. So there is also this piece around thinking of what testing looks like from a practical standpoint. So what could you say, or do you say to clients about the importance of testing? How can you relay the importance of testing to the community you serve or communities that you serve? How would you convey the importance of testing to people? Because people may not know, right, that this is something I maybe should get tested for. Educate them about the risks of like, do you mean about syphilis or just like or more so about like what can happen with untreated infection? I'm assuming maybe that's what you meant, Andy. Yeah. Yeah, untreated infection. Yeah, and the risks that it poses. Exactly. Yeah. Maybe also like many people don't have symptoms that are noticeable, right? So people might think like, oh, maybe there was something that's gone now. I'm fine. Like that might be the assumption that people have, right? Maybe also mentioning that the only way someone can know if they have syphilis is to get tested. Like that's a very common sort of response from people. It's like, oh, I don't think I have anything. And it's like, well, the only way to know is if you get tested, right? Um, Making it a part of the routine, maybe, right? Routine testing is an important health practice for people who are sexually active. Yeah, Tiana, I'm so curious about your response here and interested in learning. So, Tiana, you've written like just so that the rest of the room can hear. So, when speaking to women, she often discusses the risks for unborn babies if if the women were to become pregnant and had untreated syphilis. Can I ask also like what are steps you take because that's such a sensitive topic? What are some ways you go about making sure the client is comfortable, feels safe, feels also like, oh, okay, like I can take the step for my health, but they don't feel stigmatized. Like, what are some ways you have that conversation? Danita, thanks. Yeah, language matters, no shaming, reduce stigma, educate them. Yeah, very clear, very clear points. Like these are yeah, fair enough, Danita. Absolutely. I really like that piece around no shaming, right? What are some practical ways through language to reduce stigma? Language is so powerful, right? Any thoughts on how we can reduce that stigma? Also, just to note that I know that Anthony will be joining soon. He might already be here. Sorry, it's a really big Zoom room. So if he's not here yet, that's okay. But he will be joining soon, I think. And he'll share a little bit more as well. Who's our guest speaker on syphilis. Yeah. Yeah. So Tiana, thanks for sharing. I always start my conversation with I want you to know I don't hold any judgment towards you and don't want you to feel embarrassed about any of this. These things are very common and it's a conversation we need to have to keep you and your health a priority. Yeah, like I think this is so crucial, right? Really opening with it's not about judging and not about shaming. And I think like because we talk about this a lot, like, we're like, how can we engage more people in care? Earlier, somebody had mentioned, people like we miss people because people aren't coming in for prenatal screening. So there are things here around the gaps are social, right? Like there are resources and services available sometimes, right? Although that is also a piece where people are living in remote areas that can be harder, but where services are available, sometimes there is still a social gap in making sure that there is that access. Um, I think also like letting people know that, hey, early detection allows a syphilis infection to be treated and cured before it causes serious health damage or gets passed to someone else, including from somebody that's pregnant to their fetus, right? That testing is the gateway to a person accessing treatment. And also, for some people, it might be really helpful for them to know that, not only is their health preserved and protected with treatment, but also that a person who's cured of syphilis can no longer pass that infection to others, right? So, and then there's this piece too, if somebody is testing like negative, it's still like this gateway to prevention services, right? It's like, okay, like, you might recognize that by virtue of being sexually active, there's a risk of syphilis. So you are now engaged in services through this prevention pathway. So that down the line, as they're more comfortable engaging in services, if something should happen, then they're more comfortable engaging in testing and treatment services anyway, right? Normalizing routine testing as a way to empower people to look out for their own sexual health. Yeah, absolutely. Yeah, awesome. So now let's talk a little bit about treatment, right? And we're already seeing that there's a key piece here in terms of like, okay, accessing treatment really means people are accessing testing. That's a huge component of this this process, right? And so when it comes to treatment, syphilis infections can be cured with antibiotics, especially if treatment happens early. So early treatment keeps a syphilis infection from progressing and causing damage to a person's health. Curing a syphilis infection also prevents a person from passing it on to others. Now, ideally, right, a person who tests positive for syphilis should be treated right away. And in some cases, actually, healthcare providers may decide to provide treatment even before test results confirm the syphilis diagnosis. For example, if syphilis is strongly suspected, but a person is hard to reach or unlikely to return for another visit. And this is because, the benefits of treating really outweigh the cons here, right? Like as in, let's go ahead and treat, even if it takes some time for the results to come back. This person is here now. Let's go ahead and do that. There are some options for treating syphilis. And so there are intramuscular injections, right? So according to national guidelines, the preferred treatment for most cases of primary, secondary, and early latent syphilis is one dose of long-acting penicillin, bicillin, right? Via two intramuscular injections in the buttocks. Okay. And so this is kind of the preferred um treatment, or the one that is most commonly administered, right? There's also an alternate option, which is doxycycline. And so when you're thinking about like, okay, if people have an allergy to penicillin, there is this oral treatment, right? So doxycycline is an alternate option. It can be taken as pills twice daily, usually for about 2 weeks. But the piece here is that so doxy is not taken during pregnancy. So that's important to note. Um, if a syphilis infection progresses to the late latent or tertiary stage, national guidelines recommend weekly bicillin injections for 3 weeks or 28 days of doxy taken twice daily as pills. Oh, and we have our guest speaker joining us. Welcome, Anthony. We'll get started in just a little bit. We're just wrapping up a portion of treatment. Feel free to get a beverage, and then I'll have a chance to introduce you soon. Thank you for coming. And so what do you think? What are some strengths and challenges of these treatment options? What are some, like, maybe pros and cons, a strange way of framing it, but just what are some strengths of, the IM injections, but then what are some challenges there also? And then conversely, strengths for the oral treatment, but also some challenges. What are some things that you're noting? Yeah, Tiana, that's a great point, right? IM injections are nice because they're a one and done thing. Particularly like if we're talking about primary, secondary, and early latent syphilis, right? So it's one dose via two intramuscular injections in the buttocks. But then, there is that piece where if it's a late latent or tertiary stage, then it is weekly bicillin injections for 3 weeks. But yeah, one and done, you treat the presumptive case, and then yeah, exactly. What's a downside potentially? Maybe from a client perspective, if you're thinking. Yeah, so yeah, exactly. So we're seeing, there's fear of injections and people aren't fans of injections. Yeah, the injections can be painful. Um, but to that point, Tiana, you raise a really good point saying the pills can be difficult too because people might not finish that full course of antibiotics. And even when we say like, this needs to happen, but it's the abstraction of like if people notice, as you say, symptoms starting to get better, then they think they're better and they don't have to finish it. But of course, like, it's they've gotta uh or like ideally they finish the full course. I'm seeing injections are great if a person has adherence issues, then pills will not work. Exactly, exactly. And so, like while pills might feel like they're because it's avoiding the pain of the injection, there are some downsides too. Um, the other thing to keep in mind, um, so here's the other piece. So especially when we're considering potentially sources of weakened immune systems. So doxycycline, the way it works is by impairing the growth of treponemes. And they're sometimes used in patients who are allergic to penicillin, as I mentioned before, right? But bear in mind that doxy may be less effective in people with severely weakened immune systems. And then there's also this piece of like, if people are allergic to penicillin, but they're also pregnant, right? And so now we're running into like doxy is not used in pregnancy. And if someone is allergic to penicillin, well, then what do they do if they're pregnant, right? So what happens is actually, so some experts prefer to first desensitize their patients to penicillin. So it actually involves giving people tiny but gradually increasing amounts of penicillin under close medical supervision until they're able to tolerate a complete dose. There's some complexity here in terms of like, how to support people through this, but largely there's a comment in the chat about how the bicillin is one and done, and that is like a very useful approach, right? And yeah, Danita, that's the thing. Injections might be painful, exactly. So we'll keep going here for our sort of final poll question, and I will launch that. So this question asks, it's true or false, being cured of syphilis protects a person from getting syphilis again. Is that true or false? Sorry, I'm just going to take a sip of my coffee. I lost my voice a few days ago, and so it's still, you can hear the crackle. One moment. Just need a bit of, let's see. So about 10 people remaining. Again, nobody can see how you're responding. Answers are totally anonymous. You can only see your own name under your response to remember how you have answered. Really is just about learning. So we'll end the poll, maybe get sort of 10 seconds. Okay, I think that's about 10. So I'm going to end the poll here. About 84% of people participated. And yeah, most people answered correctly, right? So the answer is false. So what does that tell us, right? So one, people can be reinfected with syphilis after being cured. So we don't develop long-term immunity to syphilis, right? So after a syphilis infection is treated, it's still important to practice safer sex and safer injection drug use, and to get tested regularly if there is an ongoing risk of syphilis. There's no vaccine to prevent syphilis, right? So that's something to keep in mind. I have a brief video here, and we'll dive into that. Oops, there we go. Sometimes the video is a little bit finicky, but we'll do our best here. And so this is to recap what we have learned so far. It's a 3-minute video on key information about syphilis prevention, testing, and treatment that we produced in partnership with the CBRC, or Community-Based Research Center. And this is really for diverse two-spirit, gay, bisexual, and queer positive or queer plus audiences. And it's really important to note that it is specific to this this range of communities, and not all information in this video may be relevant to all populations. So taking in point that, there are folks here who are supporting largely cis women, and so this might be like not necessarily the work that you're engaged in, but also keeping in mind that, of course, gay, bi, and queer community members are everywhere. So, there is evidence to support the use of antibiotic doxycycline as prophylaxis for gay, bi, and other men who have sex with men, and among transgender women. But as a note, again, research is needed to see if it's effective among other populations like cisgender women and trans men. So let's take a look at this video. I'm just gonna make sure everybody can see the screen, but actually let me just optimize it for video sharing, and we'll get started here. There we go. Oh, and maybe there's a question in the chat. Oh, thank you so much, Janice. Janice also has the link for the video itself, so as a resource. Amazing. And I might have to use that link, actually. Let's see if this works. Nope, it's not. So Janice, thank you so much. I'm just going to click that instead of searching in my notes for it. Very helpful. That's important too. We're living in a world sometimes where we think we shouldn't accept help, but we can accept help. It's perfectly fine to do that. So here it is. And just gonna, actually just one moment. Sorry, I just realized that I have several tabs open. I want to make that screen as, as neat as possible. So yeah, here we go.
Syphilis is an infection caused by bacteria called Treponema pallidum. Syphilis is passed most often through sexual contact. Syphilis can also be passed to a fetus or newborn during pregnancy or childbirth. Syphilis may also be passed through sharing equipment like needles and syringes when injecting drugs. There are often no obvious symptoms of syphilis. When there are symptoms, the first is often a painless sore called a chancre, usually on or in the genitals, rectum, or mouth. Other symptoms can include a rash on the torso, palms, or soles of the feet, headaches, and problems with vision or hearing. Without treatment, syphilis stays in the body even if there are no symptoms. Syphilis can spread to places like the brain, nervous system, eyes, ears, skin, bones, liver, kidneys, or heart. This can lead to some serious health problems. The good news is that there are treatments that can cure syphilis and ways to reduce your chances of getting it. How you deal with syphilis is your choice. Knowing your options can help you make the choices that are right for you. Condoms can help prevent getting or passing syphilis during sex. A newer prevention method uses an antibiotic called doxycycline to prevent getting syphilis. If taken after a possible exposure, this is called doxypep. If taken on an ongoing basis, this is called doxyprep. If you inject drugs, using new equipment every time will prevent you from getting syphilis. The only way to know if you have syphilis is to get tested. This usually involves a blood test and sometimes a swab of a syphilis sore. Get tested if you have symptoms or think you've been exposed to syphilis. If you're sexually active, regular testing helps detect a new syphilis infection early so you can get treated before it gets worse and avoid passing it on. If you or a partner is pregnant or thinking about getting pregnant, get tested before and throughout the pregnancy. You might need to remind your healthcare provider to make sure this happens. When you test for syphilis, get tested for other sexually transmitted and blood-borne infections too. If you test positive for syphilis, get treated as soon as possible. If it's caught early, syphilis can usually be cured with antibiotics, given by injection at one clinic visit or taken orally as pills for 2 weeks. If you've had syphilis for more than a year, the treatment is longer. After your treatment, keep in mind that you can get syphilis again, so stay proactive about prevention to reduce your chances of getting a future infection. Make syphilis testing part of your self-care routine so you can identify a new infection early. If you do get syphilis, get treated right away. These steps will help you stay healthy, and as a bonus, help keep others healthy too.
Okay, so I'll stop my share there. And so I hope that that was a useful summary. And then let's dive into the next piece here. So, and I bet that video is going to start playing again. So just give me one moment. Okay, no, it worked. It worked. And so we're going to hear in a moment actually from Anthony. And let me just pull up my slides here. So just one moment. And we're gonna, chat a little bit about syphilis health inequities, and Anthony will share a little bit more about work that he is engaged in when it comes to addressing these inequities. But just give me one moment while we bring up the slides. So this is sort of just a national snapshot so that we can see what the context is like, right? So syphilis is a sexually transmitted infection. It's on the rise in Canada. There were 13,953 cases of infectious syphilis reported nationally in 2022, and that corresponds to a rate of 36.1 cases per 100,000 people. And regional realities may differ from these counts. You might see that it's potentially higher where you are as well, or potentially lower, right? Canada saw a 109% increase, right, in the rate of syphilis between 2018 and 2022. And we saw, in terms of congenital syphilis, we actually saw a 599% increase in the rate of congenital syphilis between 2018 and 2022. Like, that's not a typo. It's a 599% rate increase nationally. So this is, it's stark numbers. It's a very, it's a stark reality. And so, when we're thinking about why certain communities are disproportionately affected by syphilis, we really have to take into account the social and structural determinants of health. So these are factors that directly shape people's lives and their potential for self-determination. Sometimes I've seen, diagrams like this, which is really sort of a socio-ecological model, or an SEM. And the way that people often want to think about it is, it's taught sometimes to go from the individual up to the broader range. But really what we are noticing more and more is that it's the other way around, right? So factors like income, socioeconomic status, employment status, cultural norms, when we think about like a widespread social norm about shame or fear, that's a norm. It's huge. It encompasses a lot of environmental conditions that can prevent someone from getting access, right? And similarly, it's like, are we living in a remote area? Are we able to advocate for our needs, or is it that we're experiencing a lot of stigma and judgment? There's like a layer of this that can be challenging to navigate. So when we think about things like colonialism or racism, these determinants of health are, it's really not a metaphor. Like, it is quite a literal determinant of health, right? But on the plus side, we also have positives, right? So if people have housing stability, if they have social inclusion, if there is access to healthcare that is meaningful, culturally relevant, culturally rooted, then people can actually take those steps, and those individual lifestyle factors, can be impacted in a really positive way, right? So ultimately, we want to try and address health inequities, which are these unfair differences in social determinants of health. And we're going to hear a little bit more from Anthony and the work that he is doing. I know I keep saying that. We'll get there in just a little, in just a few moments. But really, there's this piece here around addressing syphilis-related health inequities, right? So this is really the piece around why we're seeing community-level disparity. And in fact, anytime we see communities being affected, we actually know that it's not individual behavior. And actually, so here we've seen from Saskatchewan Prevention Institute numbers that are relevant to Saskatchewan, what we're seeing here is that syphilis cases increased 1,444% in Saskatchewan between 2018 and 2022, which is higher than the national average, right? So certainly the importance of addressing these social factors is a really important way to tackle the unfair burden of syphilis experienced by these communities. So there is a piece here that's really about justice and care. Um, from a biological perspective, of course, syphilis can affect anyone, no matter their age, sex, gender, sexual orientation, race, or ethnic origin. But we are seeing that some populations or groups are experiencing this disproportionate burden. That includes women who are aged 15 to 39 years. It's things like, can they negotiate for safer sex? Can they negotiate for condoms? Are they able to enter healthcare spaces without fear of judgment? What are the social and structural factors they are navigating? Indigenous people are also experiencing disproportionate burdens of syphilis, but again, there's this piece around the ripple effects, the ongoing effects of colonization and colonialism, and how that is affecting the present day as well. Exactly, Danita. The impacts of colonization, and not just historical colonization, but ongoing colonialism and colonization, right? Exactly. And we're also seeing gay, bi, and queer men are having to navigate, homophobia. They're having to navigate queerphobia, healthcare that is relevant for them. Indigenous people are navigating anti-Indigenous racism, what it means to access healthcare spaces, and so on. People with a history of incarceration are at higher risk, right? Do they have tools to prevent syphilis and access treatment? People who use injection drugs, similar context, right? And again, these populations aren't always distinct from one another, and many individuals belong to two or more of these groups. I'll continue on past this discussion piece here because we're going to hear from Anthony in a moment as well, and he'll be touching on these pieces. So Anthony graduated from the NEPS nursing program at FNU at Prince Albert campus in 2009. He started his career on the medical floor in Victoria Hospital and then worked as an additional authorized practice nurse, or AAP, in primary care for several years in English River in Saskatchewan. In 2021, Anthony accepted the newly created position of communicable disease outreach nurse at Prince Albert Grand Council Health Department. And this new position gave this opportunity to focus on STBBIs in PAGC communities, and it sort of gave birth to this Wellness on Wheels mobile van. So Anthony, welcome. We'll get started here with a brief discussion, a chat on what you're seeing in community. We had such a rich conversation in preparation for this session. And so welcome.
Thank you so much for having me today. I was having some issues with my computer, so I was a little panicky a minute ago, but I think I got it sorted out. Can you hear me okay?
Yeah, we can hear you.
Perfect. So I caught a little bit of the webinar here, but I just came in not too long ago, so I might talk about a few of the same things you've already discussed. So just stop me if I'm repeating something that's not necessary.
No, all good. We've just gone over the biomedical basics of things like staging, testing, treatment, but we'll dive right in with that first question that we had, which is, in the context of your work, with the mobile van, and actually, can you share a little bit about the work you're doing with this mobile van?
Sure. The mobile van is great. The history of it is I started 2021, so mid-COVID. I took this new position as a communicable disease outreach nurse. So I wasn't quite sure what it entailed. I didn't have a lot of experience so much with public health, if very little. So it was kind of new to me. And we were still closed. The world was shut down. So we were still locked down COVID. I started this in February 2021. And the idea was there was funding for a medical type of van that could be used portably to be into our community. So we created that with a company here in town, and more or less it's a lab on wheels, which can be turned into anything, right? We could use it for primary care, for well, baby, prenatals. It's just the idea of having a vehicle that we could portably go places. So that was kind of the start of my position here, and from there it led more into focusing on the STI, especially the huge rates that we were seeing, because as everyone knows, before with COVID we weren't testing, right? So it was new to all of us. The numbers that started coming out after COVID started slowing down. And that kind of put us in a situation where I'll just explain our situation here with Prince Edward Island Council. So we have 12 First Nations. I work primarily with six most of the time. Some of our First Nation communities are more independent with their healthcare. So I will maybe do a little bit of work with them on an invite basis or a lower percentage, but six primarily that I work with. And when I started, I was used to primary care nursing where we did everything right at the clinic. And public health was different because we didn't have a lab, we didn't have ability to test or treat. That was very new. So it started as us creating, of course, lab licensing, training staff, starting our own labs, how we're going to do that. And the idea of it was that we wanted to bring health, especially communicable disease health, to the community, because most of our communities would be on a 1 hour one-way trip or a 3.5 hour one-way trip to an urban center to get tested and then come all the way home and then get results and go all the way back and then treatment and then follow-up. So as you can see, it was kind of ridiculous because it wasn't working, right? So the idea of that whole mobile van was to have access brought into the community. And then in the same realm, we created our own program in the community. So the mobile van is great. We use it for different events. And it's more of a symbol too, I think. It does help a lot, but I mean, you could do the same thing I've said before in different talks about any vehicle, right? If you're just there, if you're prepared and willing to hit the road. So it is a nice feature, but I think the idea of it was to bring more awareness to what we need in our communities. So that's kind of where we were at with our van.
Absolutely. But I remember in our prep session where the way you described it was just, yeah, there was this budget, and then it was just, like, let's make it into a lab. Let's make this van into a lab. And I was like, that's a very unique thing to do. I don't think most people would, like, it's hard to have that vision and then execute it, right? So I think that's incredible that you've gone about doing that. So I think it's wonderful that you're really practicing that aspect of meeting people where they're at and making sure that we're reaching people in community. So that's really incredible. What are some common misconceptions you've encountered about syphilis in your practice, and how do you address them? How do you go about potentially, like, building trust and so on?
I think like to this day, like when we started, I have notes beside me. So if I keep looking over, it's just to remind myself. So I apologize. I haven't memorized all this. Um, I think a lot of some of the issues right off the bat are just the awareness of what syphilis even is. I think because as healthcare providers, and in the field, of course, we're well knowledged on it because we had to be, right? I really didn't know a lot, to be honest, about syphilis because it was so foreign. So through education and learning and research, I've kind of trained and helped train other nurses to understand. So we all have a good understanding. But people in the community, just general people, if I ask them today about syphilis, they're kind of like, what is it? I was at a health fair yesterday talking to the youth, and not a community I normally go to too often, but it was the same thing. It was kind of like, never heard of it. Or if they did, maybe it was on a radio or a commercial very briefly on TV at some point. But I think the biggest thing is still people don't know what it is, or if they do know what it is, there's the fear, of course, with the stigma behind sexual health and wellness, right? So a lot of the stuff that we try to focus on is the education portion more, because there are a lot of people that don't know what syphilis is, how do you get it, like what you need for treatment, the follow-up. So it goes back to education for what I believe is probably the most important part right now. And then people that do have syphilis and have had positive results, they might not have any symptoms at all. They might never even know, and they might be in denial. So A lot of the time it's re-educating the client when you're there on the ground with them. Because there's a lot of misconceptions about it, right? Like I think you said before about the treatment too. Can you get it again? Yes, you can get it again. A lot of people don't think that. A lot of people think we're giving them immunization because through COVID, that's all we did was immunization. So I think a lot of that is just re-educating. That's a big part
Right.
of misconception.
Yeah, thank you for sharing that. And actually, I know we discussed sort of the order of questions, but I think this dovetails really well, especially after we talked about some of the inequities and, people earlier, Anthony, just so you know, people have shared that, there are barriers for people accessing prenatal care. There's barriers for, just around like people feeling judgment or shame. So I'll skip ahead to question 3 in our original list. How do you approach conversations about syphilis with patients who may be feeling anxious, ashamed about their diagnosis, or even like potentially their risk and they're nervous about getting tested even?
Mm. Um, I think a huge part of it is empathy. Um, you got to create a trusting environment, but you have to be empathetic with people in anything, not just syphilis. But I try to put myself in their shoes, just like in my career of nursing, taking care of people. I think that's a good way for me anyway, to understand that maybe like treat them like a family member. I always say, because there's a lot of fear when if you think of someone so simply as we get used to, it's another syphilis case. We'll call them in, we forget that this is a very fearful time for a person that doesn't understand maybe what's going on, where it came from, what treatment is, how to follow up. So I try to create a trusting environment. So it's very much private, right? We want confidentiality, number one. So a lot of it, the start of the conversation is about this is between me, the nurse, and you, and that's it. There's no one else involved in this. This is your safe spot. So everything we talk about is between me and you, and we will never share that with anyone else. I think you start that off as a trusting thing, and it works. It works okay. Like it works well, but it takes time. And the more I find you're in a community or our nurses that are in our communities, they develop that relationship over time where it's so maybe more openly talked about with the public and the schools that people kind of know what we do. And it starts to bring people in that normally might not have come in because it's terrifying. I think if you think about it and you come in and you not know anything, just to get the courage to come in to see the nurse about this phone call that you got and you're already scared, you don't know what's it about. Like if you think about the fear there, like we got to really kind of calm people and relax people and make it not light, but make it like there's like things are going to be okay. We can take care of this, right? Give them that kind of feeling like explain everything, but it's going to be okay. We're
Yeah.
going to manage it as long as we do everything correctly together and we work together. This is going to be okay. That's a big part of the relationship.
That's awesome. Yeah. And maybe even leading with like that this is curable. And you can protect yourself and also other people. And that, in the case of also somebody had mentioned earlier in the chat, that when it comes to discussing syphilis with women, there's that piece around like you can protect your future child too, right? Like your baby. So I think there's a lot of pieces there. And yeah, addressing the fear, and not dancing around it, but just really sort of making sure that people feel more comfortable and doing your best there. Um,
Mhm.
yeah. So can you walk us through what a typical, I guess maybe there is no such thing as a typical syphilis assessment, but what does syphilis assessment, and what does this testing process look like in a community healthcare setting? And you've been, I think, to a few different communities, right? You mentioned there's like 6 different ones.
Yeah,
What does this look like?
six I work with primarily are so we're set up that we can do testing. So some of our communities do testing, say once or twice a week automatically. So it's sexual wellness testing days, Tuesdays, Thursdays, whatever they come up with. A lot of the other things we try to do is do large community events more. So we try to piggyback onto maybe there's a cultural event going on, or there's some sort of community health fair going on, and we kind of position ourselves in the community with permission, of course, from the community that we can set up our mobile van or we can set up in the clinic or whatever, and we offer testing. So we offer the education and testing. People do come in on their own now. Like off the start, they weren't because they didn't really know, right? So we did these big events where we have incentives. Incentives vary from community to community. We've tried many different things to increase awareness for people to come. Sometimes, to be honest, it's cash. It's $10 cash to come and get tested. Some communities we don't do that. We do maybe food or a food hamper or a veggie hamper, something to bring people in. I think traditionally on First Nations, food is a big part of the community. So feasts are a big part, things like that. So we try to involve that. COVID times didn't let us, right? But now I see us, we're kind of going back to that where we'll have some sort of outdoor barbecue and then get people in. Then we do the testing. We do the testing right there in the community. And then the follow-up is usually focused with the nurse in the community, but I'll go back for follow-up too if there's a lot of cases or we're starting to flag a lot. So they can come directly back to the clinic. And that's a point where we do try to do the most of the education, I think, so they're aware about what's going to happen for the next, if it's syphilis, year, really, right?
Mhm.
And that's the hard part about syphilis because it's not like chlamydia gonorrhea where it's one and done and see you later and hopefully we're okay. But it's the constant coming back for follow-up. So it kind of gives us a chance to talk about what they're going to experience over the next year. Like we're going to contact you back. If your number changes, please call us. We'll try to find you wherever you are to offer you the blood work. And a lot of that, I think, is our hardest part because syphilis is such a long-term treatment, right? Or follow-up. So we try to offer all that right in the clinic. There are some people that would prefer maybe not to be in the clinic, maybe for familial reasons. They might have relatives or they might have family that work there and they don't want that stigma of what's going on. So then we tend to go back to, we could transfer them to a urban community close by, or we could do a possible home treatment with our van. So it varies. It's never really typically the same every day. I just got back from a community last week where I think a lot of our work is the follow-up portion and trying to find people. Like our communities are very transient, and that's a lot of reasons why, right? It's a lot of low socioeconomic status. It's a lot of people that are overcrowded in homes and physically can't stay for long periods of time, and their phone numbers change a lot, and they kind of move around either to another community or an urban center, and so we're playing this kind of tag with public health, like Saskatchewan Health Authority Public Health, because they might be living in a community for a while with the SHA, and then they might come back a month later. We don't know, right? So it's not it's that's our trickiest part because it's not easy follow up, and these are things that we're dealing with now that we're trying to come up with solutions of what might make it better. I think access to having all their information on one area, like Panorama IOM has come out, right, to follow those cases, but it's not immediate either. So, and it's a lot of training and it's a lot of work on our nurses. And I'll just make a point about the workload. I didn't see when I started this that I would bombard our nurses with another full-time job because literally that's what it is. And so we have one nurse in a community that's already doing community health nursing with the programming and the prenatals and the postnatals and the baby immunizations and the baby wellness. And then we throw on CDs, like I'm like, oh, we'll just throw this on there. Well,
Right.
it's a full-time job, and I could employ another full-time nurse in every single community just to focus on CDs, like for sure. So that's a barrier for sure, like manpower.
Right. Yeah, this is such a good point. And I actually want to say you provided such a useful counter to, and like something we had shared earlier was, at least relative to taking like the doxy pill duration, at least the injections feel like one and done. But I think you raised such a good point though that it's not really one and done because there's this like long course of follow-up. So I think that's also really important for people in the room to hear because at the time that we had that conversation, it was like, yeah, like I think like, that makes sense. But then it's like, no, it's not one and done because you do have this extended period of follow-up. What does that mean for transient populations, people who are also like, potentially at risk of like of reinfection and like there are those pieces around education And then also just the barrier, the social and structural barrier of literal manpower. Like, are there enough nurses, um, in the field? And I think what you said there was really insightful, where you're saying there could be a CD, communicable diseases nurse, that is sort of just devoted to that role itself. And that really says something about some of the gaps that are there. Um, and also the work that you're doing to address those gaps. Um, I think people learn a lot from stories or sort of lessons learned from, that are like experiential. And I'm just wondering if you can share any stories or lessons that really highlight the importance of community-based approaches, maybe culturally relevant approaches to syphilis education and care.
I think there's a strong history with trust, of course, right? Especially trust with healthcare. Um, and we've overcome a lot of those hurdles in our own communities, but I mean, it exists out there. There's a lot of inequities and there's a lot of mistrust. So it takes a long, long time to develop that. I think by being present in the communities, and we have amazing nurses. I can't say enough about the nurses that work in our communities for us. They're mind blowing, and they get to know people very personally. They're very involved in the community. It's not a job where they're just like check in at 8:30, 9 o'clock and check out. A lot of them live in the communities. A lot of them are from the communities, and they have a great relationship with people. And if we didn't have that, I don't know, like to be someone brand new off the street, which is fantastic to have a new nurse come in. It takes quite a long time. Not a long time, but it takes time to get the trust. I think that's a big part of what people maybe don't understand coming to a community that's very close, because some of our communities are not that big. There might be 1,000 people, there might be 1,500 to 2,000 people, so everybody knows everyone, and the error for breaking trust is easy. Sometimes driving a vehicle to a house is enough for people to start talking and saying, hey, why did that person go there, right? So I think a lot of it is trying to make people comfortable with what works for them. um, it's not like in the city where you would go to a doctor you probably never saw before, or and get a treatment, and nobody would know. They would know what you're there for. You could be there for a sore throat, right? So I think a big part of that is like the community needs to be an approach of a trusting kind of way to go about it. um, I wrote some notes here. I'm trying to look over here. We do a lot of here's my big pitch. This is what I really want to get into now this year is I see this gap where we have just all we do is syphilis, and we do treatment, follow up. Yes, it takes a while to do follow up. Sometimes we get a year down the road, we haven't done their 3-month blood, so we're catching up. Um, and there's a population that has missed a lot of the education portion. I think through COVID as well as other reasons that we're not getting those numbers down, and it's frustrating, but it's understandable. And I look at our youth, how we learn and how we teach, and how much like public health is based on preventative health, right, through education. So I think our biggest focus really is the education with our youth, and going quite young. Like we're in grade 4, 5, 6, 7, 8, 9, 10, 11, 12. And it's not the same, we're just blatantly talking about STIs. It's a small approach about healthy relationships, safe touch, consent, things like that. And we work our way up to the older grades where we actually test the high school students if they'd like to in the school. And I think that portion of the education is gonna be a difference of seeing our numbers drop, because healthy choices, you have a battery of information that you'll know that it's gonna help. And I think that's what the future holds for getting these numbers down for a lot of the population. There's a part of the population that we're gonna chase and we're gonna struggle with, and that's reality with a lot of things. I mean, that's not nothing. I'm not saying anything negative about it. I'm just saying it's work. But I think after 4 years of working here, I know these students in these schools. They know me. They know the nurses, and they know when we want to come and talk because we bring games and toys, and it's great. But they remember that, and they remember things that we say, and they restate them to us, and it's hilarious and it's fun. And I think that environment is what's going to help. So that's my big push. 2025 is like educate everyone about not just syphilis, like everything.
I think this is so great because so often, and I've noticed sort of, like once we have resources and things for more of like an adult population, there's a lot of like, oh, let's destigmatize, let's not talk about let's not have it be a shaming or judgmental environment. But I feel like a lot of the messaging often towards youth tends to be shaming or tends to be judgmental, but that's how some of those broader social norms are then created. So it makes sense to change those norms, right? So I think I loved what you said just now about, you want to, yes, talk about the risks, but then also talk about prevention and testing in equal measure in a non-judgmental way, and then offer those services to just normalize the process. And so yeah, I think there's a lot to unpack around how shame and stigma and fear function as colonial tools. Like there's very much this idea of like, stay away from all of this. And we know that, well, of course, like teenagers are curious and are going to explore. And so, doesn't it make sense to provide these resources and information in a non-judgmental way? Why do we wait until we're adults to have those conversations? So I think that's really amazing. Thank you, Anthony, for sharing your insights here. I'm just going to open up the floor now to invite anyone in the Zoom room, if you have questions for Anthony, to please you can share the question in the chat. You can write it out, or you can raise your hand, unmute yourself, and you can ask that question. We'll just have a brief Q&A. If folks are curious about asking Anthony anything. You can also message me privately. Trying to see if there is. We'll give folks a moment to think. And then the other piece also, as we're waiting for maybe comments or questions to come in, I'd like service providers in the room to think about these 3 questions also based on what you just heard from Anthony. So what are factors that might contribute to accessing syphilis services and prevention testing, treatment, or care? What facilitators and strengths can support access? And then in your role, what are 2 or 3 things that you could do or currently do to contribute to these facilitators or strengths? So those are some questions that I have. Anthony, a question for you regarding follow-up. You'd mentioned that there is a gap there and that you're working around it, that you're working with teens. A question though is in terms of transient populations, what are some developments there? I think you might have mentioned it briefly.
A lot of it is like we do have very reliable nurses that in our community that they know families and where they go to. There's lots of conversations had about so and so. We can kind of know where people have gone or moved to. It might be in the same community. It might be just their phone number's gone. They've moved 5 doors down. A lot of it is we try to keep up with the cell numbers and the tracking, but it's hard because people change their numbers so very, very often, right? And there's a lot of there's a good relationship with the SHA and us with 3 of our communities because they're very close by, and like we're sharing those files back and forth because we have to, right? There is someone, I don't want to say too much, but there is someone that works with the SHA side that wants to also help with these hard to reach people. So they would be under our First Nations, so kind of under my window, but they're off of First Nations land. So we're trying to make a team approach where we could work together and maybe enter the urban center with us as well as them together, where we can kind of share our information, what we have, to kind of get to these people so they can get access, right? It takes a while. There's things that we have to kind of really watch legalities and make sure we talk to the right people, and we'll make it work. I know we will, but it's just a way that we can try to work together because syphilis is everywhere. We have to work together, right? I know there's rules and everything, and I respect all those rules, and I respect the way people do things. It's just that we're trying to find a way that we can do it together. That's the biggest thing for us right now.
For sure. I think that makes a lot of sense. We want the bureaucracy to actually work to support people, right? There is a question in the chat. Are the symptoms the same for children as they are for adults? Would it appear as eczema? This is a question for you, Anthony.
As far as the rash, I'm assuming they're asking.
I think they're
Um,
asking about that, yeah.
I know that there has been cases of misdiagnosis with eczema. Not so much on youth. I think some younger adults where they have gone into a clinic, they have been diagnosed with eczema. They've been given a topical steroid cream, and that's actually not it, right? I think this was earlier on where we weren't just testing all the time. Like for a while, like our prenatals weren't getting tested correctly at the time, right? So the symptoms are so different, I would say. And for children, to be honest, our oh, I just lost my train of thought there. What a guy.
Oh,
Um,
okay. It was about symptoms being different.
Different in a way that a lot of people don't have symptoms at all, or different in a way that, like I explain to people, like the sore can be like like a period point of a pen, and it could have
Mm,
been, it could have been last month. It doesn't hurt. You might not see it. And then they kind of like, oh, I didn't really notice. So some are very obvious, right? Obvious signs, and some are not very obvious at all. And I think that fear comes in with when you have a sore or a chancre, that it's terrifying. And then a lot of time they don't come in, and then it goes away, of course, and then they think they're cured. So then you might even have a conversation saying, okay, so like 3 4 months ago, did you actually? And then after they have the results, we're done the treatment or already done the treatment, they kind of go back and say, yeah, I did actually have something now you say that. I'm like, okay, so like, but not everybody. And there's a lot of people that always say, no, I don't have any of the symptoms. I don't have any burning. I don't have any sores. I don't have any rashes. I never did. So it's tricky. That's why syphilis is such a sleeper, because um, if you just think you're okay, then it doesn't
yeah.
change anything, right?
Right. And this actually really echoes what I opened the session with around the staging. And something that came up was just that, in the older era of the syphilis epidemics in the early like 1900s and so on. So not this current, but back then, it really was known as a master of disguises. Like it's hard to know, and we're seeing that pattern emerge again. There are a couple of other questions in the chat. I'm seeing, Anthony, are all your communities all on Panorama? And the other question is, Anthony, do your nurses draw blood on infants for post-treatment follow-up, or do they need to drive to a nearby facility or hospital?
Okay, so first one, all of our communities are all Panorama IOM trained. Our nurses are Panorama IOM trained. The amount of workload that Panorama IOM consists of is pretty massive. So trying to convince all of our nurses to get all their information on Panorama IOM is hard. We went through the training. We're having more meetings coming up because it's a full-time job, just the Panorama, right? Um, and we have our own line list. Like we have our, it's like we're doing things 5 different times, like charting and then paper, and then I know we're supposed to go paperless, but it's almost impossible. And then we have our line list for our community, so I keep my stats, and the nurse knows in that community when someone new comes in for relief, they just follow our stats for our specific community, right? So we are IOM trained. I think IOM it's a lot of work, and it's a tough, like I don't want to get in trouble here, but it's a tough one. I know it was a lot of work, so I think that's kind of added more work too. And but I'm trying to work with the nurses and trying to get them all kind of adapted to it. Do we do blood on infants? We do. Um, if it's a really good situation, depends how young we are. Like we'll have, right, infants born congenital syphilis. Maybe they've been treated, but the 4 weeks before delivery wasn't there, so they're still deemed congenital. So we have a healthy baby, but a month old, like unless you're drawing blood like in a lab setting regularly, um, babies are tough. Babies can be difficult. So we do set up medical taxis with the mom for mom and baby to go at the same time. We've done babies, though. I've done babies. But I think a lot of nurses, because they're not doing this every day, like it's kind of the thing you can lose, some of the skills, and you don't want to put anyone through more pain they have to be. So
Mm.
it depends on the situation. If it's perfect situation, yeah, no problem. Are there mobile testing vans in Battleford area? So ISC had, I know, two mobile testing vans. Uh, I think about a year after we started, maybe the same year we started, maybe before, I don't know. They did have two vans. I don't know if they're still being used for testing in that area. I know there was the SHA came out with the three big mobile units, so I think maybe there's a plan for that too. I'm not 100% on that either.
I think, and I wanted to ask actually as a follow-up to the follow-up question, the piece around like, nurses feeling like skilled and like able to do this on infants and babies, and to sort of like, manage that follow-up. Is that like something you see expanding? Like, would our nurses being more trained in doing that so that there isn't that drive to a nearby facility or hospital, or does it just make sense for that drive to still happen?
Well, I think the cases like aren't that high, knock on wood,
Okay.
that we're doing a lot of blood work on babies. And the other thing I have to be careful from because I want to do everything, right? But I have to like I look at my director and sometimes it's like, okay, like we have to be careful on how much we're adding on because we're public health, we're not primary care. So there's a big difference there. So we're preventative health, we do the immunization program, right? That's kind of generally like how it's always been. So by adding on more and more tasks, we're starting to get out of the scope of where we are with public health nursing. Um, yeah, would it be amazing to do everything? Yeah, but it comes down to a lot of other things. Why are we not primary care? Probably because we're close enough to a setting, urban center setting with a hospital. But there is a need, and that's the thing I've stressed too, because our populations of our communities have grown substantially, but the staffing hasn't changed for the healthcare portion.
Mm,
So it's kind of like trying to find funding. How do I find funding to explain why the need is there, which I'm working on now is I'm trying to like find a way to put a time on syphilis, meaning that how much work is one case versus how much work is 100 cases, like out of the nurse's time, like to try to compare like the need that we need more staffing. It's tricky. I've never tried to do that before, but I'm like, it does take up so much time
right,
and
right.
and it causes a lot of burnout like every other job does, but I mean it's just another more reason to have more stresses, right? So I got to be careful how I balance what we can do and what we should do maybe.
Right. Like, and really those roles of primary versus public health, like primary care versus public health.
Mhm.
There's one final question, and I'm going to also post the evaluation link in the chat. The question is, are centers utilizing nasopharyngeal swabs for PCR as part of screening neonates born to mothers with syphilis?
I don't know.
I also don't know. That's why I'm
I'll be
asking you.
really honest. I mean,
Totally fair.
because let's say, so our prenatal program, right? We follow our prenatals as best as we can, but as I say, things happen and people are transient. So we try to get that testing on first initial visit. We do the 20 to 32 weeks gap, and then post delivery. But our post deliveries are not in community; they're all in urban centers, right? So it's kind of the testing is done there, and I don't quite know exactly what it is. I'm assuming serum blood, but
Thank
because
you.
mom would be done, right? So if mom's negative, we're not going to test baby, if that makes sense, I believe,
Mm.
for syphilis. So if mom pops a positive in between the time that she was treated and or not treated and she was negative and then positive before delivery because there was a window there, then I'm not sure, but I'm assuming, um, yeah, they'd be
And
followed up in the hospital.
and Janice has confirmed, so saying that NICU teams will take a nasopharyngeal swab in acute care.
Oh, there
So
we go.
yes.
Thanks, Janice.
But I just wanted to say, Anthony, thank you so much for your thoughtful reflections and responses here. I think people have learned a lot from what you've had to share. I also wanted to thank the Saskatchewan Prevention Institute for inviting us to present on syphilis. I've included a workshop evaluation link in the chat. Shouldn't take longer than 3 minutes to fill out. We'll also send it via email. I'll send that to Abby at the Saskatchewan Prevention Institute. And there are a few reflection questions just to take away from this session. So things like, how can you use this information in your daily work? And what can you do to continue learning about syphilis after this workshop? So thanks very much. And I'll turn the mic over to, oh, sorry, Anthony, go ahead.
I just want to thank for having me here today. I'm sorry if I rambled and talked nonsense, but I appreciate it. It was it was good. It was fun, and I appreciate it very much from all of you.
Thank you so much, Anthony. And over to you, Abby.
Yeah, well, thank you so much, Shreya, for the excellent presentation. And big thank you to Anthony. I really do appreciate you speaking specifically on the northern and rural Saskatchewan context. I think that's a very important piece, specifically addressing the inequities there. I have learned a lot from both of you. And thank you to everyone for attending. Just a quick reminder, I will send out a recording of this workshop in the next couple of days, and to please fill out Shreya's evaluation. But yeah, thank you so much, everyone. I hope you all have a great rest of your day. Thank you.